I'm Jennifer Mbuthia. I'm actually a retired Army colonel. So I've been in Hawaii for almost 7 years. I did my pediatric residency at Tripler, but I've only recently kind of emerged into the larger medical community here in Hawaii after my military retirement. As I said, I did pediatrics. I spent a couple of years as a general pediatrician, and then I decided to do a fellowship in allergy and clinical immunology. So I completed that at Walter Reed. I did a lot of different jobs, utilizing my medical brain in a lot of fun and in different ways. And then just as I was getting ready to leave the military, I qualified to sit for the clinical informatics boards, and I was able to pass that. So I maintained my board certification in PEDS, allergy, and now clinical informatics. I work in clinical informatics, and I also do allergy work for the Queen's Medical Center. Most of my clinical allergy immunology stuff ties to COVID-19 vaccines. And then I also do consulting work with the Pacific Basin Telehealth Resource Center when it comes to training, education, and brainstorming and strategic planning for launching telemedicine, because that was another hat that I once wore in the military. So that's me. And I decided to retire in Hawaii. And so now I'm here, but originally born and raised in New York. So sometimes I talk fast, sometimes that's a benefit. But I'm excited to talk. I oftentimes, when I make lectures that are structured for primary care providers, I really just reflect back on my own experiences, things I wish I had known or knew more about back when I was just a regular general pediatrician, like so many of you guys. And I have no conflicts of interest. These are some of the objectives that I hope to touch upon. So very briefly, just so everyone knows, I put more information than I generally will touch upon in the slides because I usually like for my slides to be something that people can actually use as a resource later. So with that, a little bit about some food allergy terminology. The way that food allergy, a true food allergy, is defined is that it's an adverse immune response that occurs reproducibly on exposure to a given food. And the element of the food that triggers that immune response is called an allergen or a food allergen. And it's a specific component of the food, and most often it's the protein-based component of the food, and it's recognized by some arm of the immune system. And like I said, it's in a reproducible manner. An important take-home message is that sensitization is just evidence of specific IgE in the serum, but sensitization does not equal allergy. A food allergy needs to have some sort of clinical event or symptoms that go along with it. And then tolerance versus food intolerance, very, very different words. So tolerance is when somebody who had evidence of a food allergy is now able to consume that food upon some sort of re-challenge. So they have developed a tolerance to a food that they previously had a demonstrated food allergy to. Oftentimes we'll just say, or parents will say they outgrew their allergy, versus food intolerance, which is a non-immunologic reaction to a food. So something like lactose intolerance, that is not a food allergy, it's a food intolerance. A little bit more about food allergies. I'm sure this is not a surprise to anybody who works with children because there's a larger perception of the existence of food allergy than what is real. So approximately 20 to 25% of the population believe that either themselves or somebody in their household has a food allergy. But in reality, about 6% of children and 3 to 4% of adults have food allergies. And so I consider food allergies in a broader sense a more so pediatric presenting problem, especially in the setting of atopy and the atopic march. An important thing to keep in mind is that food is the most common cause of outpatient anaphylaxis, and peanut accounts for the most common trigger of fatal reactions in North America. So this chart just kind of outlines the percentage and where that 6% and that 3 to 4% come from. So important to know and be able to recognize and understand in very young children, milk and egg allergy are at the top of the list. Now, of course, prevalence of food allergy is much higher when it's assessed using a self-reporting tool versus actual testing results and evidence via food challenge. And allergy to things like food additives and preservatives is an exquisitely uncommon thing, but oftentimes falls into a layperson's misunderstanding of food allergy versus food intolerance. So oftentimes it'll get reported, oh, I'm allergic to this preservative or this additive, so I can only eat organic food because I'm allergic to it. And they actually may have no issue, or it's an intolerance. Here's some good news, and this is why young children with milk or egg allergies especially should be referred to an allergist, because about 80% of those are going to resolve. And the timing of resolution, the studies have gone all the way out to the age of 16, but in real life clinical practice, most of those kids are going to be able to fully tolerate milk or egg, depending on what their food allergy was, by around first or second grade. So 80% outgrow it. The opposite is true with peanuts and tree nuts. So some do develop tolerance to those early presenting food allergies, but these statistics are flipped. About 80% of peanut and tree nut children don't develop tolerance to their food allergy, but about 20% will. So hypersensitivity reactions, this is where we kind of put on our med school caps real quick. There's 4 categories of the Jelen-Coombs reaction. So type 1 is IgE mediated, immediate hypersensitivity. Most commonly, we think of it as anaphylaxis. Type 2 is your cytotoxic reaction. Type 3 is immune complex mediated, and type 4 is the delayed type reaction. Now, for the purpose of food and food allergy, we're just going to look at the bookends: immediate type and delayed type. So type 1 IgE mediated, that's your classic anaphylaxis. But also pollen and animal allergies are a type 1 mediated hypersensitivity. It's just that the reaction happens at your mucosal surface. But that's why when we do skin prick testing, it's to assess immediate hypersensitivity. We're looking for evidence of IgE that is attached to mast cells, and that through the skin prick, we try to elicit a mast cell degranulation locally on the skin. So the skin prick testing for food and for pollen, it's using the same mechanism to try to trigger a response. Also, the FDA approved serum allergy testing is also looking for evidence of IgE. Type 4, which is your delayed type hypersensitivity, can also be applied to food. So that's why I kind of just go into detail about those 2 bookends. Now, of the 4 hypersensitivity types, it's the only one that's not mediated by an antibody at all, but it is mediated by sensitized T cells. So the type of hypersensitivity that I'm sure all of us have gone through at some point in our professional career for employment is the tuberculin skin test. That is looking for an assessment of sensitized T cells. And that's why you have to go back and they look for a reaction or a read at 48 to 72 hours. So the onset is not immediate. Other things like nickel allergy, latex allergy can cause this. And for those of you who have mangoes in your backyard and we're approaching mango season, this is the kind of reaction that happens when somebody gets, if they're sensitized to mango sap, and they essentially get a poison ivy type of reaction from handling the mango. But that's because of the hypersensitivity in the sap. That's very different in terms of being an allergen from being able to eat the mango, which would be, usually it's tolerated. So most people who get that rash on their hands from touching mango sap can still eat mango. They just can't handle those fresh mangoes, but they can eat the mango safely. And then also you've got eosinophilic esophagitis, which can get very confusing because there, especially in children, there are also elements of IgE sensitization because about half of EOE children are also atopic. But the mechanism itself in terms of eosinophilic inflammation in the esophagus is presumed to tie mostly with T cells. So this graph, this flow, it's not even really a flow chart, just flow of words. I did not create this. This was from the American Academy of Allergy, Asthma, and Immunology, but it shows that allergic food reactions, so true food allergies, do span beyond just anaphylaxis. And the mechanisms are different over time. So things like celiac disease or food protein-induced enterocolitis or FPIES, those are all true food allergies because it involves the immune system and the food in a very reproducible manner. The downside when it comes to evaluation is that we only have testing to validate IgE-mediated reactions across most of this. Now, obviously, you can do testing for celiac disease and dermatitis herpetiformis, but with eosinophilic esophagitis and FPIES, most of your decision-making and clinical assessment really ties to the clinical history, biopsy, or physical exam of the patient. Another IgE-mediated process is oral allergy syndrome or food pollen syndrome, which I will talk about a little bit later. But the IgE-mediated ones are what an allergist can do skin prick or serum testing for with a lot of reliability. So a little bit about cow milk protein. This is the first foreign protein that's introduced into an infant's diet. Keep in mind, food allergies are not just about anaphylaxis. So milk protein is the most common allergen in very young children because they have IgE reactions, but also there are a decent percentage of children that have non-IgE mediated food allergic reactions to cow milk protein, including things like FPIES. Another important thing, so for the children who have milk protein enterocolitis, about 50% or more will also have similar reactions to soy protein. But it's the cow milk protein because most of the presentations are not just going to be IgE, but will also be non-IgE mediated, most common allergen in young children. Egg allergy, or chicken egg specifically, is the most common IgE mediated food allergy when it comes to pediatric patients. Everybody worries about the yolk versus the white. So the yolk is less allergenic than the egg white, but realistically speaking, especially if somebody's looking to do cooking at home, the risk of potential cross-reaction or contamination is so high that I generally lump egg allergy as egg allergy. So I don't tell a parent, well, only separate out the yolks and cook with those because there's still a really high risk that there will be some egg white protein that's in there. Another good news story is that half of children with a true IgE-mediated egg allergy can tolerate eggs that have been extensively heated, so eggs that are in baked products. That's also a good indicator that this is a child who's probably going to outgrow their egg allergy. So you may see that some of the oral food challenges that happen in very young, in very young, whether it's with egg or milk, step one may be that first we go to extensively heated or baked products. So we'll do baked milk, cooked milk, or baked egg. And I try to explain to parents, or even when ascertaining a history, to see if your child reacted to scrambled eggs, have they ever consumed something that had eggs that was put in the oven? Because the temperatures are obviously very different. And so if a child is tolerating baked egg product, but then has anaphylaxis to low heat or stovetop cooked egg, generally I want to maintain that tolerance that they already demonstrate. So that's a pretty in-depth discussion with a parent to talk about what to continue in the diet versus what to avoid, and also how long things should be baked, because you don't want underbaked products and have the risk that there's still some egg protein that hasn't been denatured enough. Children with a history of egg allergy, even if they've had anaphylaxis, can still receive the flu vaccine. This has been debunked by so many different organizations as not an issue or concern for over 10 years. I still find it surprising, even in 2020, 2021, that there's still a lot of healthcare workers who think that if you have an egg allergy that you cannot get the flu shot. And believe it or not, I have had patients who were referred to me who still had not had an MMR vaccine because of the urban myth that if you're allergic to egg, that you could not receive an MMR vaccine either. But it is a true concern if someone's going to get the yellow fever vaccine. So of all the vaccines that have some remnants of egg protein, yellow fever vaccine actually has the highest amount. So if a child has anaphylaxis to egg and they're going to be traveling internationally, I would have an element of caution and potentially see if it can be arranged to have that patient undergo a graded dose challenge of the yellow fever vaccine in a setting that can address and recognize and treat anaphylaxis. That's probably only ever going to be in the setting of an allergist's office, not in a travel clinic. So hopefully I've debunked the myth right there that egg allergy and flu vaccine are in conflict. No, they're totally good, but I will continue to put this up there until 1 year. If I could get one flu season where nobody says, well, what about egg allergy? Then maybe I'll stop, or maybe I won't. Peanuts. Peanuts are the most common food allergen in children 4 and older. And that just kind of goes to show how early some children can outgrow their milk and their egg allergy. Peanut products can retain some allergenicity, except if they're exquisitely highly refined. And this can be a challenge for parents to sometimes find. So if you see things that are like cold pressed, the extruded oils can still contain protein, because remember, most of your food allergens are the protein part. So the oil or the lipid component isn't what's allergenic, but how the oil is extruded allows for some protein remnants to be there. And so that's why it should only be very highly refined. Usually though, I will tell patients, just read the label and don't go anything near potential peanut. About 30 to 50% of peanut allergic patients are also going to be allergic to at least one tree nut. So peanuts, while a legume and not a tree nut, they have a higher association of seeing tree nut allergy as well. But tree nuts are a different food category and food type from peanuts. I put this chart up here just for your own reference, because sometimes this question comes up. So, can a kid who's a peanut allergic child have other legumes? The cross-reactivity rate is less than 90%. So most of the time, yes, they can. Also, I've had questions about like different kinds of animal milk, and if someone's allergic to cow milk protein, can they have goat's milk or sheep's milk? I've even seen mare's milk be asked, but I have no idea how they would get a hold of that. So this is more for reference to kind of help guide some of the education and advising of what other things they need to be mindful of avoiding. So I'm going to talk a little bit about food allergy and testing. And so I've already mentioned our testing modalities, but to go into a little bit more detail about some. So you've got your skin prick testing, which is that immediate test. You do the prick on the skin with a little bit of extract, and you're looking for mast cell degranulation because of IgE sensitization. It's red about 15 to 20 minutes after it's placed. Serum IgE testing is looking for the same thing. Now, when you're doing skin prick testing, you are triggering a histamine reaction. So that's why people cannot be on antihistamines or histamine blocking drugs. But serum testing is not measuring a histamine reaction. Therefore, for some patients who they have awful allergies, they have incredibly itchy atopic dermatitis, and they really cannot stop their antihistamines for a couple of days, ideally 7, but even 5 is better than none. Sometimes serum testing is really the better or best option. I've also had pediatric patients who, because of their atopy and atopic dermatitis, there isn't a area of really nice, pristine skin to be able to do testing. So in that case, we may end up going to IgE testing, serum testing. There's 2 generations of serum testing. The first one is radio allergosorbent testing, RAS testing. So when people talk about RAS testing, you're technically referring to first generation testing, which is no longer the standard of care. Second generation testing is what most testing facilities are now using, and it's technically not a RAS test, it's an immunocap. Does an allergist know what you're talking about? If you say, should I do RAS testing? Absolutely, we know what you're talking about, because when you put that order in, it's probably going to be an immunocap. But if you look through records, you may have a patient who's maybe like 14, 15, or 16, and they had allergy testing when they were 2 or 3. If the number is in the tens of thousands, it was a first generation test, because second generation testing only goes up to 100. So you're not going to get a measure that says 4,000 or 52,000. You're going to get a measure that at its maximum will be greater than 100. And so the scale is now what you will find in the literature for reference points. So if you look at the old first generation testing, those results are not really interpretable based off of all of the literature standards. And I say that because if you look and it's like, oh my God, your RAS test says it was 500, but you're using second generation logic, you're going to think this person's really allergic. And when in reality, 500 is basically like a 0. There's also something called prick testing. And that's where, let's say somebody didn't react to your prick test with your extract, but it's something like a fresh fruit or food, especially if it's got some kind of fluid to it. So let's say a cucumber, you could prick the fruit and then prick the skin with it and see if that elicits a reaction. The gold standard allergy evaluation is an oral food challenge. And the gold standard is not necessarily the in-office standard. And I say that because if a child regularly eats a food without any issues, they have met the threshold for the gold standard. If you eat something all the time and you don't have a problem with it, you're not allergic to it. So if you tell me that I eat shrimp every week, I eat shrimp every week, and I've eaten shrimp every week, that's actually protective from becoming allergic to it. So it's sometimes what I call the life test. But when we do it in an office setting, then it's called an oral food challenge. And there are instances where that is the step to take in terms of the evaluation, especially if the testing is coming back and it's all very negative and the history is kind of squishy. We also will do an oral food challenge in a clinic to identify who has gained tolerance or to confirm it. You don't do an oral food challenge on somebody who you have a high suspicion will react, because you're going to trigger anaphylaxis in your clinic, and most people don't want to do that. So usually with a lot of due diligence, you are only doing oral food challenges on your patients who are the lowest risk for a reaction, or the ones who are most likely to pass it. A little bit about some serum testing. This is probably where, when I was a general pediatrician, again, it was a lot of first generation tests. So I was like, ooh, don't know what to do with this number. And then you would see the second generation test results, depending on where the patient got their testing done. But this is probably where well-meaning clinicians have a step and a misinterpretation. So I thought it would be valuable to just kind of spend a little bit of time here. So your immunocap testing, again, is taking the serum, the patient's serum, you look and you pull out the immunoglobulin E, and you're looking to see if it binds to certain immunocap allergens. And that's great. It's a fairly specific and pretty sensitive. Skin testing itself is more sensitive than serum testing, but depending on what the clinical situation is and the clinical capacity, the age of the patient, or co-medications, serum testing is really, it's really pretty reliable. So you've got greater than 90% sensitivity and specificity and predictive value with your environmental allergens. So if, let's say you're worried about someone having an aeroallergen sensitivity, allergic rhinitis, you can reliably do your serum testing. The sensitivity goes down a little bit when it comes to venoms, foods, some of the weeds, latex testing, and then especially with IgE drug testing, or testing for drug allergies with IgE. Most of what you'll find or be able to even order is going to be the penicillin components. So in patients where there's a high clinical suspicion for, let's say, a penicillin allergy and it wants to be confirmed, you're better to go the route of skin testing and an oral challenge with amoxicillin instead of only relying on the serum testing. So false positives with immunocaps. This is where I think it's hopefully going to improve some of the approaches that you take with ordering, in particular with your highly atopic children. So really atopic kids have a lot of serum IgE. They just have a lot of IgE. The problem with immunocap testing in those patients is that there's a very high risk of getting false positives because of non-specific binding. They just have so much IgE circulating that you get a lot of non-specific binding on the test. A lot of things light up as positive. You should suspect this if you do a couple of IgE tests, especially to unrelated things, which hopefully after this you won't even be doing that, but you get a bunch of weekly positives. So it's that like, it says 0.6 and this one says 0.9 or 1.2, but then you also have a value that says, greater than 100. If everything on the test has some element of positive according to the lower limit, and the patient has a history of atopic disease, before you go over the results with the patient, you should probably take a pause and maybe talk to your friendly neighborhood allergist about interpretation. The reason why, so skin prick testing and elevated immune caps, all they indicate is sensitization. And remember, sensitization does not equal allergy. Sensitization just means that there's, potential for some IgE there. So your pretest probability has to factor into how you interpret things, but also when it comes to food, what it is that you're ordering. Now, the higher that IgE, or the more pronounced that skin prick, urticarial, wheal, and flare appear, the higher the chance that, yes, this is a true positive. This gives some sort of clinical reaction. But it cannot necessarily predict the severity of the reaction. And that's why I've oftentimes, I cringe a little bit when I read the results of immunocap testing in the lab review, and it says like low positive, moderate risk, high risk. Because in particular, when it comes to food, that's not how allergists really advise if someone has true IgE mediated food allergy. So it falls into the category of, do I think that this patient has the risk of having an IgE mediated systemic reaction to the food? And if the answer is yes, then it's a matter of avoidance and EpiPen and label reading and education. But unfortunately, when some tests get interpreted and they are technically negative, but above that threshold for negative by the labs system, patients walk around thinking they have, 6 or 7 food allergies, but only one of them is considered severe. And you can imagine if a child is getting ready to go to school, or they're going to go to a birthday party, or going to summer camp, how it can pose a challenge for the care providers to understand, okay, little Susie's got 8 food allergies listed, but then in parentheses, this says mild, and what does that mean to that person who's supposed to be minding this child and other children? And so that's why I think it's really important to try to avoid circumstances where misinterpretation of the serum immunocaps leads to an impact on that patient. Very young children where this misinterpretation happens actually have a risk for some nutritional issues, and also parents, in particular moms, can carry a higher rate of anxiety because they're afraid of feeding their child anywhere that's not food that they specifically prepared. And so really making sure you do right by the patient and right by the parent is important. And the reason why I say all this is because these are the levels for recommended interpretation based on the top food allergens in both, this is both adults and children. Excuse me. So as you can see, wheat, you aren't really even thinking wheat's positive until that number is way up there. Same thing with soy. Now with fish, this is talking about finned fish, not shellfish. But the recommended threshold and interpretation is younger for milk and egg in younger children. And this is where you have to have a complete story, and the results of the testing are just an element of the story. They are not the story. This is also why food allergy testing, it's not designed to be a screening test. It is meant to be a confirmatory test in the setting of a clinical history that makes sense for possible food allergy. So if I am doing testing for milk and egg on a child, it's because the history of the reactions ties to milk and egg, and there's a reproducible element to it. So if the child had a clinical reaction to peanuts and they eat milk and egg, I don't test for milk and egg because the history doesn't suggest it. And then what happens if the result comes back and it's 1.5? Because the system, the computer system, will flag it as a technical positive result. But the patient was eating the food, so because they were eating the food and eating it regularly, I should not have ordered that test anyhow. I've seen a lot of patients. I've even had referrals for children with no food allergy, and the parent just wants to know if they have any. And I was like, food allergy testing is not a magic 8 ball. I guarantee you, if I'm getting these referrals, then you guys are getting these questions clinically. Can you just test to foods? I want to know what foods they're allergic to so that I know what to feed them. The testing is not designed to be used in that manner and should not be used in that manner because there's going to be a risk of false positives, but also, are you maybe giving false reassurance? Because then if the kid has a reaction to peanut and mom's like, but I got tested and the testing said they're not allergic. So if the test result doesn't impact anything or shouldn't impact anything moving forward, then that's kind of your out to say to the parent, it's not a screening test, it's a confirmatory test. So common pitfalls, doing testing for foods that are not clinically indicated, ordering too many tests, and then misinterpretation of results, use of it as a screening, and using food allergy testing, and I'm very specific about talking about FDA approved testing For symptoms that are intolerance symptoms, there are some non-FDA approved tests out there for food intolerance, and they test to like hundreds of foods. Those are not FDA approved, and so allergists don't do food intolerance evaluation and testing. We do food allergy evaluation and testing. Real brief, I had mentioned pollen food allergy syndrome. This is a very, it's an interesting situation of the immune system cross-reacting and giving some local symptoms. So the pollen sensitization happens first. So the patient has a bunch of pollen allergies. And so therefore, you can't have food pollen, you can't have oral allergy syndrome if you don't have pollen sensitization first. Now, the thing with pollen sensitization in pediatrics, you have to be exposed to several seasons of pollen in order to become sensitized to it. So that's why pollen sensitization typically doesn't happen in those very young. It's usually around age 4, maybe age 5 at the earliest. The most common time frame is actually when they hit those double digits. So the preteen and the teens up through early 20s, that's the window of time where you exponentially increase your pollen sensitization if you're going to be pollen allergic. But you have to be pollen allergic to have food pollen syndrome. But the pollen you're allergic to may not be here in Hawaii. So you may have patients who maybe they lived in Germany and then they lived in Virginia and now they live here. And so some of the trees that they are allergic to aren't here in Hawaii. So they're not having allergic rhinitis, they're not having itchy eyes, but they still are sensitized to, let's say, birch pollen. And the elements of the pollen that the IgE binds to have homologous elements in some fruits and vegetables in their uncooked form. So the reaction is happening to cross-reactive proteins, but those proteins are very heat labile. So if you cook the tomato or you cook the apple, it quickly degrades those proteins. The proteins are also in higher amounts, oftentimes on the skin of the fruit. So some people will say, if I peel an apple, then I don't get that itching in my mouth. But if I bite into an apple, or if I bite into an underripe apple, I get it. But if the apple's overly ripened, I don't get it. If those are some of the things that people report, so they can eat tomato sauce, but they can't eat a raw tomato, or they have oral itching when they eat grapes, but then nothing else ever happens, and they have some aeroallergen sensitivity history. This is what you should think about, pollen food allergy syndrome. So it can also vary with seasons. So when that pollen season is high, they're more likely to have oral mucosal symptoms. So basically, the oral mucosa thinks the patient is eating pollen. And in these situations, these patients don't develop anaphylaxis because it's the labile protein. So it starts to get degraded by your oral enzymes and also your stomach enzymes. So you can have oral symptoms, lip symptoms, tongue itching. You might even have a little bit of lip swelling, but you're not going to have systemic anaphylaxis because that component gets degraded before it triggers system-wide issues. But this is commonly mislabeled. And, you know, as a retired colonel, I would come across situations where someone's labeled as having severe food allergy, but they have pollen food allergy. And when they try to apply to join the military, they get blocked. And so we have to kind of deconstruct where that came from, and it turns out it's their pollen allergy. And so the military will allow people with pollen food allergy syndrome in without any specific waivers because they don't have a life-threatening issue. And these are some of the common ones that go on, but not all of these are present here in Hawaii. So again, they may not have the sensitivity, the rhinitis. It doesn't mean that they don't have the pollen food allergy syndrome. A few more kind of cross-reactive issues, latex food syndrome. So these are for people who are anaphylactic to latex. There's a higher risk for developing anaphylaxis in particular to tropical fruits. So this is something that you might see very easily here in Hawaii. Mango, avocado, banana, passion fruit, those are very common foods that if someone has a latex allergy, especially, it's usually the latex allergy that will present first. And over time, they become anaphylactic to some tropical fruits. These are patients who probably should get some kind of pre-warning and counseling. They should already have an EpiPen on hand, but before they eat, kind of tropical fruits, especially, you want to make sure that they are aware of the potential. And even if they can eat avocado, they may, after several months of not eating avocado, then upon next exposure actually have anaphylaxis. And then there's one it's a little gross when I think about it, but then it makes sense, is the arthropod shellfish cross-reactivity. So some patients who are allergic to dust mites and to cockroach, if they're allergic to the kind of the tropomyosin element of shellfish and snails, you can see that cross-reactivity also exists. It's not that uncommon, but it's not super common. Most people aren't eating cockroaches. I mean, they might, and dust mites are too tiny to actually really ingest. So bottom line, some pearls of wisdom. If a child eats a food regularly, don't do allergy testing for that food. If there's a concern for the very rare unicorn situation of someone having severe atopic dermatitis that is food driven, which does happen, but it's rare. And it is that severely atopic, very bad atopic derm, despite maximum management in children under 5, send them to the allergist. Let the allergist do the detective work. Don't order serum testing. The laboratory cutoff results, it's either going to be 0.1 or 0.35. But the actual clinical, the actual cutoff that is in the literature for different foods is not the same thing. If a child has hives every day, they have hives every day, it's not a food allergy. So please don't do food allergy testing, and don't ask parents to keep a food diary, because it's not the food. But you have hives every day, you are not having anaphylaxis every day. That's not compatible with life. Broad food allergy panel testing is not indicated. It's never indicated. There's the one caveat though, is if a person is allergic to, if they have a clinical reaction to a tree nut, I'll do the tree nut panel with peanut. If they have a clinical reaction to one shellfish, I'll do the shellfish panel, but that's a modified, very specific family panel. It's not broad-based panels. There is never going to be a clinical situation where ordering a big, broad array of foods is ever going to be clinically indicated. So here's a quick food allergy myth that I continue to be shocked. I was like, people still think this? So it is a myth that if you're allergic to shellfish, that you cannot get radio contrast media or iodine. Totally a myth. Totally a myth. Now keep in mind, the shellfish allergy is to the protein component of the shellfish itself. Radio contrast reactions don't even involve IgE. It's an anaphylactoid reaction. The radio contrast directly pokes the mast cell. So it's not even plausible that the radio contrast and the shellfish are using the same mechanism. One is an IgE reaction, one's a non-IgE reaction. Shellfish allergy is not a contraindication of radio contrast or iodine. Also, if somebody has a radio contrast systemic reaction, it doesn't mean that they're allergic to shellfish. Another food allergy myth has to do with something called lecithin. So lecithin is a fatty substance. So you may see soy lecithin or egg lecithin in pharmaceutical things and in some foods, but lecithin is a fat, it's not protein. Most of your IgE mediated food allergies are protein. So therefore, if it's not the protein component, most people with a true food allergy to soy or egg can safely receive drugs or foods that have soy lecithin or egg lecithin. So the amount that's contained in it is so residual that it's unlikely to trigger a clinical reaction. And an example is propofol. I've gotten tiger text messages from colleagues in anesthesia asking about propofol. And I was like, oh, the only reason to worry about a propofol allergic reaction really is in a patient who has a history of allergic reaction to propofol. And in the studies that looked at propofol anaphylaxis, mechanistically, it's not the same as egg or soy, but also the vast majority of those people have no history of egg or soy allergy or egg or soy sensitization. So allergists don't tell people to avoid products based on the lecithin element of it. So history should guide everything. I've already talked about the non-FDA approved tests. Allergists, we don't do them. I don't interpret them. Oral symptoms, fruits and veggies when they're raw, allergic rhinitis, think pollen food allergy syndrome. And if you suspect anaphylaxis, prescribe EpiPen, especially for school. Don't just send the kid to school or camp or daycare with antihistamines. They need to have an EpiPen on hand if they're truly anaphylactic.